Assalamu alaikum. I'm Dr. Sidra Ishaq. I am an assistant professor of pediatric critical care medicine in the Department of Pediatrics and Child Health and an associate program director for residency program pediatrics at the Aga Khan University Hospital. I shall be discussing assessment of the critically ill child. I do not have any financial disclosures to declare. So the objectives of my presentation would include recognizing respiratory failure and describing the clinical features of the different types of shock. Discuss the approach to cardiopulmonary evaluation of a child. Apply the PEWS, that is Pediatric Early Warning Score, to detect clinical deterioration early. Apply the ABCDE systemic approach to evaluation and discuss the early recognition and treatment of sepsis. So, what is a critically ill child? WHO defines pediatric critical illness as any severe problem with the airway, breathing, or circulation, or acute deterioration of conscious state. This definition was formulated to provide guidance in the management of the most common life-threatening conditions in children presenting to hospitals in resource-limited countries, namely hypoxemia, circulatory impairment, and seizures. This is from the WHO Pediatric Emergency Triage Assessment Guidelines of the Critically Ill Children. There's a very interesting definition for acute pediatric critical illness, DEFCRIT, that recently came out, and it basically divides the critical illness into subdomains. And a very essential statement too states that Tier 1 or patients at risk for acute critical illness are those who might have one or more abnormal physiological parameters. So whenever we're actually talking about a critically ill child, it's very important for us to lay emphasis on these physiological parameters that include vital signs, which may actually be, for example, hyper or hypotension or blood pressures centiles that are more than 95th centile or less than 5th centile, or more or less than second standard deviations for age, in the absence of clinical support, example, inotropes. Tier 2 is acute critical illness, in which patients presenting with acute critical illness might have persistent worsening for more than an hour of one or more physiological parameters or vital signs, including more than 95th centile or less than 5th centile, or again more or less than second standard deviations in the absence or despite the clinical support. So the difference being is that Tier 1 basically is in the absence of clinical support in resource-limited settings, whereas in Tier 2, we're talking about those that may or may not have the clinical support, right? And the time frame may actually be variable depending on the clinical condition. However, if they have persistence of these symptoms for at least an hour, they will classify into Tier 2. So it's very essential for us to be able to recognize the danger signs and the physiological abnormalities and in a critically ill child. So let's move on to the rapid assessment. So the rapid assessment, as most of us are aware, includes assessing a critically ill or a sick child's airway, breathing, circulation, disability, and exposure. Let's now look at the Pediatric Early Warning Score, which is known as PEWS. And this is a very good score, especially at the bedside, and it helps you decide where to triage the patient and how you can actually escalate the level of care being given to the patient just in case the patient becomes clinically ill or the clinical condition deteriorates. So as you can see, if you move across the score from left to right, so you can see that the score starts from 0 and goes up till 3. And if you move down, so you can actually look at the clinical symptomatology. So it's divided into cardiovascular, respiratory, and behavioral state, and with a maximum score of 3 on each and a minimum of 0 on each. Let's just look at, for example, a score of 1. And if you look at cardiovascular, for instance, so this may be a child who's paid or a capillary refill of 3 seconds. If this 1 progresses to 2, so the pallor would actually become gray with a capillary refill of 4 seconds, that is beyond 3 seconds, and a tachycardia that is of 20 above the normal rate. Similarly, if you look at respiratory score of 1, this is anything that's more than 10 above the established baseline. If this score was going to move to 2, this would become more than 20 above the established baseline. And behavior or the clinical neurological state, as most of us know, would be somewhere where a patient is irritable but consolable in stage 1. And if you're moving on to stage 2 of PEWS, so that child may be irritable and inconsolable. And if you move on to 3, maybe lethargic, confused, or even with an altered mental sensorium, and may have reduced response to voice or pain. So if you move across the spectrum from left to right, it's basically the worsening of the cardiovascular and the respiratory and behavioral status. So these are some of the principles of rapid assessment, and this is actually from the Society of Critical Care Medicine. So once you've actually identified, now we know what PEWS is, we can determine the clinical state of our patient at the bedside. So these are some of the tools of communication and rapid assessment whenever we're talking about assessing a critically ill child. So D stands for detection, I is for intervention. So you've detected that the patient is ill, I is intervention, R is reassessment, E is for effective communication, E and C, and T is teamwork. So all of these form very essential pearls of communication around rapid assessment of a sick child. General assessment would be the most important part of physical examination, and PEWS is something that would expedite the evaluation process at the bedside. The focus, as we discussed, would be on the behavioral, cardiovascular, respiratory status. So those are the 3 things that we need to focus. So once you've already been through the ABCDE, you've looked at the airway, breathing, circulation, disability, exposure. Next, you're going to look at the cardiovascular status, and PEWS would be one of the best tools to help us decide this. And then you look at the respiratory and, of course, the behavioral status. Eventually ask yourself, whenever you're looking at any kid, that does this child look sick, or does this child just does not look healthy? Further, moving on to the general assessment, you already looked at the initial presentation of the kid. Then you looked at the skin, whether there's mottling, warmth or coolness, or capillary refill time, signs of dehydration, for example, sunken fontanelle in infants, tears in mucous membranes, skin tenting, and if there's central cyanosis and acrocyanosis, and jaundice and pallor. Breathing, you would have to look at the accessory muscle usage. You will see if there's nasal flaring, grunting, intercostal recessions, bradypnea or tachypnea. And remember, whenever you're talking about children or pediatric population, everything has to be age defined, right? So there are specific cutoffs that PALS, that is pediatric advanced life support, or defines for specific age groups. So any bradypnea or tachypnea is basically defined on that basis. And if you're talking about stridor and audible wheezing or any additional sounds. Alertness, neurological status, behavioral assessment is based on AVPU. A stands for awake, V responding to verbal commands, P is painful stimulation response, and U is unresponsive. This is a lot more handy when it comes to assessing the GCS or clinical score, neurological score of a child. GCS, of course, you're going to mark him on a score of 15 when you're taking components that are eye, motor, and verbal, as opposed to alertness AVPU, which is a very handy and a brief score, if you want to learn at the bedside, whether the child is awake, following verbal, commands responding to pain, or responsive or unresponsive. And PEWS we've already discussed. So just expanding onto the cardiovascular status, you're looking at the skin color, you're looking at the saturations, we're looking at the temperature, cap refill, and similarly respiratory, we've looked at the danger signs. This pediatric assessment triangle actually forms the core of all assessment of sick children or a critically ill child whenever you're talking, right? So it basically is divided into 3 components. We've already discussed this, and the SPAT, or the Pediatric Assessment Triangle, just summarizes and collates everything together. So the appearance is, you can actually look at the tone, the gaze, the cry, whether the child is consolable or inconsolable, and eventually coming to the question that does the child look sick. You're talking about the work of breathing. We're looking at the breath sounds, if the positioning helps to make it better, nasal flaring and retractions. And circulation, looking at pallor, mottling, and cyanosis. So this would be an initial screen and should suffice to actually let you know whether this child needs an escalated level of care. Moving on to the primary assessment. Now that we're through with the PEWS, we looked at the ABCDEs, we've looked at the cardiovascular, respiratory, neurological status, and of course, a bit of history taking in detail. We move on next to airway. So very essential, we need to understand the differences between a child and an adult's airway. And why is it very important to understand these differences? Because a newborn child's head is generally very huge, contrasted with the body. And the head will generally become flexed which may actually cause obstruction of the airway. They also have big tongues that tend to fall back and eventually obstruct the airway. So it's very important to adequately position a child's airway and to clear the airway and maintain the patency of the airway when we're talking about airway and resuscitation, managing the airway of a child, right? Infants, especially nose breathers, obligate nose breathers for in the initial half year of life. And again, they have short vocal cords, the epiglottis is U-shaped, the larynx is located at C2. In adults, it's going to be somewhere between C4 and C5. So all of these factors predispose to a high-risk airway or an airway that requires immediate attention whenever we think the child is getting sicker. And less than 8 years old, the children's larynx has a funnel shape, and the narrowest section is actually at the subglottic cricoid cartilage level. So we've already discussed this, and this figure basically helps to elaborate it a little more. The proportionally larger heads, flaccid tongue that tends to fall back, obstruct the airway, infants being obligate nose breathers, again, larynx being more superior. So infants and young children will rely on the diaphragm to breathe more than the adults. So that's the reason diaphragm becomes one of the accessory muscle usage whenever the child becomes tachypnic or is developing respiratory distress or respiratory failure. So this is something we've already looked at, and there's a larger floppy epiglottis, anteriorly placed larynx. So this is very essential whenever we're talking about a pediatric airway management, how the positioning has to come about, how to clear the airway. So all of these are basic steps once you actually recognize that this is a high-risk airway in a child, right? And the clinical exam would actually help us identify the airway obstruction in children, whether this is stridor or wheezing, which means if it's airway obstruction that is above the thoracic inlet, it's going to be stridor. That's mainly inspiratory. If you're talking about expiratory obstruction or a lower airway obstruction, then the child may present with wheezing. So stridor and wheezing are signs of respiratory distress. They may also be signs of impending respiratory failure. It's very essential for us as pediatricians or healthcare workers or physicians at the bedside to be able to recognize these signs in a sick child. Respiratory failure classification based on age. Prematures may actually have apnea of prematurity or respiratory distress syndrome. Neonates may actually develop respiratory failure because of infectious causes, congenital airway abnormalities, and infants and toddlers may have lower airway disease, parenchymal disorders, bad pneumonias, ARDS, and all those presentations leading to respiratory failure. Some of the ancillary studies to evaluate respiratory distress include an arterial blood gas, and we may look for hypoxemia, hypercapnia, and acidosis. Pulse oximetry is a non-invasive method. So even if you do not have an arterial line or we cannot do invasive testing, pulse oximetry again, would be there and would be able to monitor oxygenation response to treatment also. But again, having said that, we would not be able to monitor for ventilation. Hemoglobin is there, capnography is there, chest radiography. You may actually look if there's airway obstruction, if there's pneumothorax, or parenchymal lung disease or atelectasis. So circulation assessment in children, after you've looked at the breathing, you've looked at the accessory muscle usage, we looked at the ancillary testing to evaluate respiratory distress, we next move on to assessment of circulation. And this would actually be based on 5 Ps. So very important for all of those who are taking this session is that whenever you're looking at circulation, so always remember these 5 Ps, which include pulse. The pulse volume is also important, whether this is a thready pulse or a full volume pulse or a bounding pulse, because that may dictate the clinical condition that the child is in. Peripheral perfusion, preload, that's the volume status of the child, dehydrated or adequately hydrated, and blood pressure. So these are the 5 Ps that one needs to understand, recognize, and evaluate once we are dealing with circulation of a sick child. And accordingly, the circulatory status will be determined as normal or compensated versus decompensated shock. And then the intervention should start by the degree of dysfunction or circulation. These are some of the normal heart range for different age groups, just like we discussed for the respiratory distress. So these are the normal heart rates. So like on an average of 140 for a newborn, 120 for somebody who's less than a year old, and then around 90 to somebody who's 6 to 8 years and over. Some physiological considerations of circulatory system. Tachycardia is a very essential earliest predictor, earliest marker, indicator of increased cardiac output or a patient who's getting critically ill or under stress. Blood pressure would vary. It's not uncommon for children to be tachycardic and have normal blood pressures because it takes time. The body tries to compensate, and then the patient may actually be in a compensated state, and then the blood pressure would probably start dipping down once the patient has decompensated, right? So, and a good formula for hypertension is, or blood pressure, the systolic blood pressure equals to 70 plus 2 into age in years. So this is somebody who's 2 years and over, and this is how you can do. And then for mean arterial pressure is less than 40 plus 1.5 times age, but a good one to remember, 70 plus 2 into years is important. Children can lose up to 30% of blood volume, still have normal blood pressures, and not go into hypotension. Some physiological considerations of circulatory system include the Frank-Starling curve. The cardiac output is basically heart rate into stroke volume. That's important. And the stroke volume, as we see, so if you look at this diagram here, the left side or of the axis, basically the y-axis shows the stroke volume. The stroke volume is essentially the preload, the afterload, and contractility. This may be a little beyond the scope of this presentation, but we just need to understand what the cardiac output actually depends on, right? So the preload is the volume that the patient has or the fluid that you're giving to the patient. Contractility is the ability of the heart to contract, right? And of course, you're talking about, so this is volume against the ventricular preload. So this is what this graph shows you. Now we move on to a very important component of a critical child presentation, which is shock. And this is defined as a state of cardiopulmonary dysfunction that fails to provide sufficient oxygen and nutrients to meet the metabolic needs of vital organs and peripheral tissues. Compensated shock is a compensatory mechanism that maintains perfusion blood pressure by increasing the heart rate and SVR, that's systemic vascular resistance. Decompensated when all the compensatory mechanisms fail and the heart starts to fail, and overall the child goes into signs of multi-organ dysfunction. And it's essential once you're talking about shock, so you all can actually go up and go back and look this up and look at the different types of shock. Some important ones to mention here include cardiogenic shock. That may myocarditis may be one presentation, maybe just as simple as tachycardia, eventually leading to cardiogenic shock, and may present with signs of cardiac failure like tachypnea, crackles, hepatomegaly, organomegaly, failure to thrive. Duct-dependent lesions are very, very important because they get picked up in the early neonatal age when the duct is trying to close. So they may present with cardiogenic or obstructive shock, absent femoral pulses, cyanosis, diminishing urine output. Lactate, carbon dioxide, and hemoglobin and the urine output are some of the important ancillary tests to evaluate a cardiovascular system. Just like we looked at the blood gases in the respiratory system, it's important for us to look at the lactate and the carbon dioxide to look for any acidosis, and of course the bicarb level too. And of course, if there's invasive monitoring, so we can look at the arc line of flow or diagram the arc line flow, the graphics, and we should be able to monitor the inotropic and the vasopressor therapy. And similarly for the CVP, it actually helps us to assess the preload, the volume status of the patient. Looking at the X-ray, the ECG is absolutely essential. So what you're trying to do is you're actually trying to screen all the multi-organ dysfunction by looking at all of this. So finally, moving on to some last few slides of my presentation, looking at the checklist evaluation approach for critically ill child, we looked at the PAT. So the PAT, remember the Pediatric Assessment Triangle, which includes the airway, breathing, and the body color or circulation. Airway appearance, you've already looked at, how the child looks, if the child looks sick, what kind of appearance the patient has. Breathing, you've already looked at the parameters, and then the color. Then you move on to primary assessment, which is ABCDE. And of course, you need to be aware about and also look at, while you're taking the history, digging out the sample history and the secondary assessment. So basically looking at the signs and symptoms, you're looking at the medications, last meal taking by the patient, past medical history, any exposures. It's important that alongside this, you look at the vital signs, you look at the AVPU score, or you look at the clinical neurological status or the GCS, and understand the importance of airway differences between a child and an adult. So let's just wrap up the presentation. A toxic appearing child is usually a critically ill child. A child's perfusion is best assessed by mental status, capillary refill time, urine output, temperature of extremities. Hypotension, as we said, is a very late finding. of shock. Initially, it would be compensated, and you may have tachycardia in the absence of hypotension. Early signs of respiratory distress may include tachypnea, grunting, retractions, nasal flaring. This is absolutely essential. We've looked at PEWS. We know how to score the patient on PEWS. Timely recognition and aggressive intervention essential to optimal outcome. With that, I thank you for your patient listening.